Rajesh sir, kindly start.
Okay, so welcome back everybody again to a new episode of our Casebook Live. And you know that this is a very interesting session, it's problem-based learning actually. So we discuss from the very basics and we try to dissect the case as would happen in a real life. And today we have two very eminent personalities with us. We have Dr. Vibhor Borkar sir and Dr. Anil Tambe. Both of them are pediatric gastroenterologists at Nanavati Max Super Speciality Hospital, Mumbai. We have two PG participants today from Dr. D.Y. Patil Medical College, Dr. Mrinali Thakur and Dr. Arthi Muthukumar. And the mentor is Dr. Sanjay Sawan sir, who is a professor of pediatrics at D.Y. Patil Medical College, Pune. So let us start straight away. So this is a 1.5 months old boy, like 1.5 month old boy, second by order, and he's born to a third degree consanguineous marriage. And he has come with chief complaints of loose stools since 1 month, fever for the last 4 days, decreased oral intakes in the last 3 days, vomiting for 2 days, and abdominal distension for 1 day. So these are the chief complaints. So although the complaints date back to 1 month, the recent complaints led the child to the hospital. So I would like to ask the postgraduates here, Mrinali and Arthi, as to what are your thoughts about these chief complaints?
So it looks like a case of chronic diarrhea, sir, since the
Okay.
complaints of loose stools are since 1 month, sir. And right now, since there is fever, decreased oral intake, vomiting, and abdominal distension, um, there can be an infection present right now, gastroenteritis.
Amongst these five complaints that are there, which complaint worries you the most?
So loose stool since the last 1 month, sir.
Okay,
Along,
you're not worried about the abdominal distension?
and along with abdominal distension, sir, right now.
Okay, what could be the possible causes of abdominal distension in a baby with chronic diarrhea?
Mm. So, mm, lactose intolerance, sir.
Why would it cause abdominal distension? Think of something common that you see every day for which you might do an ECG. You might have to run an infusion. We never give the drug fast IV. So maybe a hypokalemia, something like that, isn't it? Okay, so what details do you want? What details do you want from me for these complaints? Do you want some details from me?
Yes, sir. Like electrolytes, sir.
No, that is
CG.
investigation, isn't it? First, about the symptoms. What
Yes, sir.
details about the symptoms you want?
So any blood tinged stools were present or not?
Very good. So you want to know whether there is blood in the stools or not. Okay. What else?
Mm. And
Any poor weight gain, weight loss
Okay.
history.
Yes. Okay. So you want to know whether the child is gaining weight or losing weight or not gaining weight. All right. Anything else?
or consistency of loose stool, sir.
Okay. So you want all the details of the stool, isn't it? What the
Yes, sir.
physically the stools look like. Okay. We'll go to the details now. So this baby was apparently all right a month back. So when the baby was 15 days old, he started having loose stools 10 to 12 episodes per day. Suppose you are the pediatrician at that time and the mother comes to you saying that, my baby is having loose stools and the baby is passing 10 to 12 loose stools every day. Would you worry about it or you would not worry about it?
It's a 1.5 month-old baby, sir. Usually,
Okay, so breastfed babies, can they have 10 stools every day?
Yes,
yes,
sir.
sir.
Loose, isn't it? We say golden yellow, slightly loose.
Yes, sir. Mucoid
Okay.
inconsistency.
Right. So initially this stool was yellowish and what happened was initially it was semi-solid and then it became watery and it became little large volume. There was no blood, it was not foul smelling. The child was active, playful, he was breastfeeding well. So mother was not really worried about it, so she did not seek any medical attention. But she did notice that the baby is not gaining weight adequately. So she thought that this is the second baby. So she thought that the baby is not gaining weight as much as the first baby did. So she finally consulted some physician nearby, GP some nearby, and she was given some oral medications were given. And then the mother actually took the medication. Okay. So the stool, you said it was initially 10, 12 episodes per day. Now it increased to 15 to 20 episodes per day. It was dark green in consistency, mucoid, sticky and foul smelling. So initially it was non-foul smelling, it was watery, but then it became dark green and mucoid. So this is what the stools were like when the baby was brought to our hospital. The fever was there only for the last 4 days. It was insidious onset fever, high grade fever, intermittent, and it was followed by decrease in the activity of the child. That worried the mother that the baby is not playful, the baby is not feeding well, and vomiting was also there, which was non-projectile, non-bilious vomiting. And just one day before, she noticed that the baby's abdomen appears quite distended. So mother got worried. Her main problem was that the baby's abdomen looks distended. So that was her main worry when the baby was brought to the hospital. So negative history, there was no cow's milk, no formula. Mother does not like milk or milk products. She does not take any milk or milk products at all. There was no rash in the baby. There was no perianal excoriation. There were no bilious vomiting, blood in stools, no decreased urine output. Okay, but the child was also not having any increased respiratory activity or irritability. So the child was not having other symptoms per se. Okay. Antenatally, it was uneventful. The birth history was all right. Baby was breastfed exclusively, no NICU admission. Okay, so we already highlighted that there is a third degree consanguinity here. So that is the only thing that was there. Otherwise, the baby was all right. Baby was exclusively breastfed, remember that. Okay, so initially I'll ask the postgraduates to summarize the case and then we will ask the experts what they think. Yes, Dr. Aarti and Dr. Minanari.
It's a case of a 1.5 month old male child of second birth order born of a third degree consanguineous marriage with complaints of loose stool since 1 month, fever since 4 days, and vomiting since 2 days, associated with abdominal distension and reduced oral intake. Uh, um, Associated with
What is your impression like on history? You have this history in mind. What are you thinking about now? You summarize the symptoms correctly. Do you want to know something more from me? I did not tell you about abdominal distension actually. You should have asked me. So the distension was, it was throughout the abdomen. It was not localized to upper abdomen or lower abdomen or flank. Mother said that it was a generalized distension which was there. So what are the possibilities? What are you thinking now with the rest of the history? Has it made any, addition? Your negative history and detailed chief complaints. Has it added anything to you, to your diagnosis? Okay, I'll ask Dr. Vibor now. Sir, what are your comments on this case so far, on the history?
Yeah, hi. Very nice and interesting case, and probably the first slide hints towards the diagnosis. We'll come to how to analyze this case. Now, at looking at the chronic diarrhea, so it's the 4 weeks history of diarrhea. This classifies as a chronic diarrhea. Now, we have aptly gone into the details of the diarrhea. I think that well covered about whether it is a small bowel, whether it is a colitis. I will only add the one component of a malabsorption, that is there is any lactose intolerance component, okay, which can also add to the abdominal distension. Plus, was there any flatulence? You mentioned about the perianal rash. So if it's an acidic stool, definitely that will contribute to the perianal rash. Now, if you see that for 1 month, this child continued to have a diarrhea, and the significant deterioration occurred in the last 5 to 7 days. Now, so what is this deterioration? That basically compel the mother to seek admission, to seek the doctor's advice and then admission. So this distinction is really worrisome and it can be life-threatening also. Now, as sir has already hinted that it can be an electrolyte imbalance. Yes, it can be an electrolyte imbalance for a 1 month duration. But apart so, what else is it that electrolyte imbalance will cause and it cause an ileus. So basically, you are dealing with a diarrhea followed by some motility issue. Now, this motility issue can be, then we need to find out what can be the motility issues. One thing is, yes, it can be an ileus, sepsis infection, which is progressing and causing a septic-related ileus. That's one thing. Second thing, it can be an electrolyte imbalance related ileus, like a hypokalemia. Okay, so odd point for that is then once this happens, your stool frequency goes down. Here, that has not happened. The stool frequency has in fact increased along with the abdominal distension. The third possibility is here, are we dealing with enterocolitis? Which is started and now the child abdominal extension. So this can present with the Hirschsprung disease, which is the first presentation of Hirschsprung disease, which is starting from this is the age in the second and third week. So as a pediatrician, our understanding is Hirschsprung disease is a differential diagnosis of constipation, but it's not like that. Hirschsprung disease, one of the presentation is constipation. It doesn't mean it doesn't present as a diarrhea, it doesn't present as a failure of the bowel. This is a common age where the first presentation of Hirschsprung disease is this. So that will be very important diagnosis where it will in fact come as the first differential. Okay, apart from there, I am not right now taking into the picture. On the history as a student, one should also with the abdominal distension, is there visible bowel loops? Okay, if the mother is seeing that the like a tire kind of things which is horizontally running bowel loop, that history I will like to ask. Anything? Maybe Anil, you can add your.
Very nicely presented and summarized. So few things from my side was as we discussed that this is diarrhea which has been going on for 1 month with a recent deterioration. So apart from the points which Dr. Vibhor rightly mentioned, few things which we would add is once we are trying to correct the electrolyte imbalance and the possible sepsis and other things, I would also want to know what happens to the child's diarrhea when the child is not feeding. So for whatever medical reasons, because the child is sick and abdominal distension is worsening, if we keep the child nil by mouth, what is the status of the diarrhea? That will give me a lot of answers to my questions and try to bring down the differential diagnosis, whether it is a osmotic or a secretory diarrhea. That's when my differentials will vary. That's one thing. Secondly, when the child is having this abdominal distension, as Dr. Vibhor rightly mentioned, we want to look for any visible bowel loop. But apart from that, is there any blood in stools as well? So that will point again towards enterocolitis. So if there is any blood in stools, visible bowel loops, the abdomen is tender, the child is septic, sick looking, these points will help me to add to my narrative more.
Absolutely agreed, sir. So the only thing was this was also a malnourishing diarrhea. The baby was not gaining weight. So I wanted to ask, is in Hirschsprung, if there is a diarrhea, does that result in a malnutrition is what I want to ask.
Yes, sir. It will be a part of the enterocolitis.
Right.
Because of the small bacteria, it will be a stasis. The diarrhea, it's actually because of the small bowel and small intestinal bacterial overgrowth. And that will damage the mucosa. There will be a mucosal atrophy, and it is actually in fact failure to thrive is one of the presentation is one of the presenting symptom of Hirschsprung's.
Great. Okay, so actually we did not think of Hirschsprung's, and I'm very happy that you brought out this point. So what we thought that this was the history, and we thought this is some chronic diarrhea, maybe infective, maybe some malabsorption with failure to thrive, and in an exclusively breastfed infant whose mother does not take any cow milk or cow milk products. So that is what we thought. So on examination, the child is sick looking. As sir said, it is important to see if this child is sick looking or well looking. And this child was sick looking. There was severe pallor. The anterior fontanelle was sunken. The oral mucosa was dry. The skin pinch was delayed. And here the vitals, the child was febrile, 102, the heart rate was 180 per minute. The child was tachypneic, 48 per minute. The pulse oximeter was okay. Central pulses, peripheral pulses were palpable. The blood pressure was okay for the age. The sugar was okay. And there was no other icterus, cyanosis, lymphadenopathy, etc. was not there. So I would like to first ask the postgraduates as to what is the important examination finding in this, and does it add anything to your history really?
And signs of dehydration were present, sir.
Correct?
And pallor,
Severe pallor. Severe pallor, yes.
So, and
I think the most important thing is sick looking child, febrile child, isn't it? So it tells you that this is an acute infection, isn't it? This is an acute infection. That is, so enterocolitis you must consider at this point very strongly with dehydration. So this is what the anthropometry was. The baby was just 3.2. Remember, the birth weight was 3.1, and at 1.5 months, the baby is now 3.2 kilos. So the baby is crossing centiles. If you can see here beautifully, the baby is crossing centiles. So baby is actually failing to thrive. Now this is the head to toe examination, nothing really except for the anterior fontanelle, which was sunken. And this is the systemic examination. So per abdomen, we found that the abdomen is distended. We could not see any bowel loops per se. There was no flank fullness. The umbilicus was inverted. Hernial orifices were normal. Genitalia were normal. And on percussion, the liver was 2 centimeters below the costal margin. It was a soft, round, non-tender, smooth surface. It was a normal liver. The spleen was just palpable. And the liver span was 7.5 centimeter. Okay, so this the only thing that examination added was a little bit of liver and spleen palpable, which we thought was not say the liver span is okay. 7 centimeters, 7.5 centimeters is not a bad liver span. So that is what we thought. So what are your thoughts now, Aarti and Mrinali? Dr. Aarti and Dr. Mrinali, has anything changed post the examination, your abdominal examination?
No, sir. The only thing
What other information you want from me? I have not given that information, but what other information you want from me? Shall I auscultate or not? Remember, this child has an abdominal distension. I am in PICU.
Yes, sir. Sir,
So what are you auscultating for?
whether bowel sounds are present or
Correct. Okay, so you want to know whether the bowel sounds are present or not. So that I have not shown. And there was no tenderness per se. The abdomen was not tender. The child was irritable in general, but there was no tenderness guarding rigidity specifically anywhere. But there was severe dehydration, anemia, no hepatosplenomegaly. So that is what we thought. Dr. Anil, Dr. Vibhor, any thoughts on this?
Just bowel sounds, yes, definitely. Apart from that, perianal evaluation. Again, very important because your diarrhea and the abdominal distension. Need to look at the spine also. Now at this age, we are doing a PR is challenging, but it is not. It's not like that is not possible. But don't do a PR. We must do an X-ray. PR should be done after the X-ray abdomen. So as a student, you should mention that if possibility, I might consider PR examination. That's it. You may not do it, but we're looking at the size and all. But pay attention to that also.
There was no perianal excoriation, rightly brought out. There was no excoriation. We did not do a PR. We did a X-ray.
Okay.
Okay, so let's go forward. So this is the day one lab. So if you look at the lab, you can find that the day one hemoglobin was 8.1. And on the ABG, what is your interpretation of the ABG? Can somebody, one of the postgraduates? How was the anemia? If you look at the MCV, MCH, RDW, what type of anemia is this? Is the MCV 95 normal at this age, 1.5 months old?
no, sir.
Okay, it is normal. Okay, so newborn babies and babies till around 3 months, say, they tend to have little higher MCV. So that itself does not tell that it is B12 deficiency. Okay, so it's not a blastic type of anemia. It's normal for this age. That's why I have not highlighted it. So the hemoglobin was low and the electrolytes were okay. The potassium was on the lower side, 3.7, but it was not abnormal anyways. And look at the ABG and can you tell me what you think in the ABG? What is the interpretation of this ABG?
It looks like metabolic acidosis, sir, because pH is on the lower side, so 7.29, and bicarb is also 9.1, sir.
Okay, what is happening to the CO2? I know that this is not a ICU case per se, but you would anyway look at the PCO2. Your comments on PCO2.
It's reduced.
Okay, so it's compensating. The baby is trying to, have tachypnea, trying to breathe fast and remove the, trying to correct the acidosis rather. Okay. So that was the thing. And then we have the rest of the investigations now, which were very interesting. Okay. So the peripheral smear was normocytic, normochromic. The IT ratio was 0.18. Platelets were adequate. There was nothing much on the smear really. But what we found was that the CRP was 88. The INR, interestingly, was 3 here. And the APTT is also deranged here. The bilirubin is slightly high with mainly direct hyperbil. The amylase and lipase are very low. And so is the entire lipid profile. Cholesterol is low, triglyceride is low, LDL is low, everything is low. HDL is less than 5. I have not seen HDL less than 5 in my life. So this was a little surprising for us. So what do the postgraduates think? Did you expect this? Was this expected when you sent the investigations?
No, sir.
No. So how do you interpret this in the light of the history now? You have a baby with chronic diarrhea and possible enterocolitis, and you have these bloods.
So liver is involved, liver and pancreas both
Okay, we'll go step by step. Your CRP is 88. What is it telling you?
infective, sir. Infective or
Infective. All right. Okay. Your INR, I'm so sorry. Okay. Okay. The INR is deranged and so is the APTT. What does that tell you?
So coagulation defect, sir.
Coagulation problem. Very good. Okay. And what about the amylase, lipase, and the lipids?
Reduced. They're
Very low,
reduced.
isn't it? We don't see it, isn't it? We don't
Yes,
see it routinely. So I want to ask the experts, if this was the blood, what would you think now?
So with this with this PT-INR of elevation of 3, I would want to give a vitamin K and repeat the INR and see whether that is getting corrected or not. That's one
Fair
thing.
enough. Yes.
Yes. Along with that, with such a low lipid profile, then we would start to think of orbital hyperproteinemia and diseases like that, which comes into picture, which presents with congenital chronic diarrheas and a little bit of hepatomegaly and other systems involved. So that thing does come in picture. Did we repeat the PTINR after giving vitamin K?
So I'll come to that. What about the amylase and lipase? Because even that we did not expect that it will be low.
At this point in time, I'm not sure how to interpret that.
Right. Okay. Dr. Vibor? Sir is there? Is he connected or is disconnected?
He's disconnected. Maybe he'll
Disconnected. Okay. All right. So, okay. So we were very surprised to really have these results in a child with chronic diarrhea. And so we started thinking, what is this? And as you said, we gave vitamin K and we repeated the INR again after 12 hours and 24 hours, and it was still abnormal. So I want to ask the postgraduates, how will you interpret that? Your INR is not getting corrected by giving vitamin K. What does that tell you? So it improved to 2.2 or something, but it did not get normal.
The synthetic function of the liver is affected, sir. So
Okay, so I'll give you two conditions. In one condition, you give vitamin K and the INR normalizes. And in another condition, you give vitamin K and the INR does not normalize. So how will you interpret this?
If it's a hepatic cause, then even after giving vitamin K, it will not normalize.
Okay, it will not normalize if there is a severe liver dysfunction. That is what you want to say. If it is just a vitamin K deficiency, it should be a correctable coagulopathy. And if it is not, if it is severe, like an acute liver failure or something, by definition, in PALS, we say that, it's uncorrectable coagulopathy by giving vitamin K. Dr. Anil, anything to add about this vitamin K and PTI?
No, I think that is absolutely correct. We give vitamin K if it is not corrected, it means that the hepatocytes are involved, and just giving the vitamin K is not going to synthesize the coagulation factors. So that's
Great. So we can see here the SGPT is normal. The SGOT is slightly high, but the child is anemic also. So we were not worried about that. The gamma GT was okay. The albumin is okay. It is not too low. The albumin is also not too low. So we were confused. Now, is this a liver? The bilirubin is slightly high. So we were confused. Is this liver disease, or is this just a small bowel diarrhea which is causing, malabsorption, causing this low lipid levels, low amylase? Is it a result, effect? We were not very sure what is happening. Meanwhile, we got the stool also report. So in that, we can see that, we had a semi-solid sticky mucoid. A lot of mucus was present. Blood is absent. Occult blood trace is there, but lot of fat globules. So they reported it as fat globules more than 50 per high power field, and lot of pus cells and a few RBCs. So I would ask Dr. Mrinal, what is your interpretation of this tool routine microscopy? We'll go to the X-ray a bit later. What is the interpretation of this tool routine?
So steatorrhea is present, sir. Fat is present.
Okay, so correct. So there is steatorrhea. What else is there?
Trace amounts of occult blood with 3 to 4 RBCs.
Very good. Okay. All right. So a lot of pus cells, few RBCs are there. And you would think that this is some kind of enterocolitis-like situation which is happening here, isn't it? What about the X-ray? Postgraduates again?
So there's gaseous distension of the abdomen.
Okay.
The loops are dilated, sir.
The loops are, bowel loops are dilated. All right. Okay. Anything else? All right. So Anil sir, about this tool routine and radiograph, any inputs?
So the stool routine, I would say there is definitely some component of malabsorption which is going on. There is plenty of fat globules which are seen. Pus cells, yes, the child is having diarrhea. There is some amount of sepsis going. There is fever, so we can expect the pus cells to be there. There is no occult blood. A little bit of RBC is present. Culture has shown no growth. So there is a combined picture of the gastroenteritis or enterocolitis which is happening along with the component of malabsorption. Yes, for sure.
Excellent. Excellent. So we'll go forward now.
Yeah.
So initially what we did was we corrected the dehydration. We gave some potassium, vitamin K we gave. Should we keep this baby NBM? Should we give antibiotics, probiotics? What do the postgraduates think? Dr. Mrinal?
So we need to start antibiotics. Give first dehydration correction and then start on antibiotics as well, sir.
Okay, so this is a sick child, and I think the WBC count is high, the CRP is high, we are suspecting enterocolitis. Okay, so I would give antibiotics for sure. Okay, what about probiotics? You want to give probiotics?
Yes, so we can give probiotics.
Okay, I'm not so sure about probiotics at this stage. What about keeping the baby nil by mouth? You would keep the baby nil by mouth, or you'll feed this baby? If you heard carefully, Dr. Anil said something when we were on the history.
So we'll keep the child NBM, sir, so that we
Okay,
can
so-
rule out any
Right.
lactose.
So why do you want to, why do you want to keep the child NBM? What will it, how will it help?
So lactose intolerance or yes, sir.
So for lactose intolerance, remember there is no perineal excoriation per se.
Yes, sir.
Okay, Dr. Anil sir, your thoughts?
So I'll take the last point first, which Dr. Aarti mentioned about the keeping NBM and the intolerance thing. So regarding that, what we are actually wanting to look at is whether the diarrhea is secretory or osmotic. So that will tell me whether things are wrong at the mucosal level, at the enzyme levels, or in the lumen. So if somebody who is kept for nil by mouth for 24 to 48 hours and the diarrhea decreases significantly, so the stool output goes from 12 to 14 times a day to 3 to 4 times a day, that means that that is an osmotic diarrhea wherein the interluminal contents are not getting digested. That is causing inflow of water, and that is causing the stool output. So there, your differential diagnosis go to a different direction. And when even after keeping Nilbam, the stool frequency does not go here and there, it is still going high in the range of 12 to 14. There, that means that there is an active secretion going on. There is something wrong at the mucosal molecular level, wherein your channels are abnormal, and that is causing active secretions of electrolytes and along with it water, which is causing the diarrhea. So that gives me a whole lot of answers what happens after I keep NBM. So at least 24 hours of Nilbam will work. And I'm really not sure. Less than 6 months, not a very good idea, I would say.
Kept the baby NBM, we added antibiotics, and despite giving vitamin K, as I said, there was not much improvement. So we decided we'll give FFP because this child was sick looking and there was blood in the stool. So we decided we'll give FFP. Do you agree with giving an FFP here, Dr. Anil?
No, not really. So if it is a liver dysfunction, that as and when what we are suspecting, so the liver will act in both ways. It is secreting both pro and anticoagulants. So vitamin INR D9 does not necessarily mean that it is going towards anticoagulation until unless we are planning a little procedure like line insertions or some intervention. As long as that is not in the picture, we would not want to give a FFP. Provided the INR, if at one certain point in time when the INR goes beyond 4.5 or 5 or 6, that's when we want to give prophylactic. But at this point, prophylactic FFP is not on the cards.
Absolutely agree with you. So generally we follow that INR more than 4. Generally we keep it as a threshold. But here we gave FFP because there was some blood in the stool. We thought that will give FFP here. Okay. So next 3 days, baby was continued on, dehydration was going on. And 4th day, we repeated the hemogram and we saw that the hemoglobin has now fallen to 6.1. So I want to ask Dr. Arthi, why has the hemoglobin fallen? Is there so much bleeding that the hemoglobin has fallen? What has led to the fall of the hemoglobin?
The stool for occult blood was positive.
Okay, so do you expect that stool for occult blood positive to cause a drop in the hemoglobin by 2 gram% over 3 days? So actually it is hemoconcentration. So when the baby came, remember the baby was dehydrated and you actually corrected the dehydration. So this is just a kind of a normalization of what the hemoglobin was always 6.1 because of dehydration. There was slight probably hemoconcentration. And therefore, you had figure of 8.1. And remember, we said there is severe pallor in the examination. We said there is severe pallor. With 8.1, you would not get such severe pallor. And here it was severe. So this is the real hemoglobin. What you're seeing now, 6.1, is the actual hemoglobin. So because the hemoglobin was very low, the child had some tachycardia. So we decided to give a PCV transfusion. And after giving transfusion and fluids and everything, the acidosis also improved. The baby vitally improved. And over 48 hours, almost 24 to 48 hours, we kept NBM. And the stool output improved. Now, by that time, we had already given antibiotics. We had given a PCV, we had kept the baby NBM, and then 50% reduction was there in stool output. But the color of the stool and the consistency were still the same. So that was what was happening with this baby. Okay, so you can see serially here how the pH improved and the bicarb improved. The INR after giving FFP improved. Later on, the INR became normal. And the APTT also became normal. So we'll come to this little later. We'll come to this part of the table later. Now I want to draw your attention here. So the other, so we repeated this was the day 1 was high. Okay, so this is infection related probably. So we ignored that. Okay, so now this table. So here we have plotted the serial levels. So initially the bilirubin is little on the higher side. It comes back to normal. The CRP has decreased, the INR has decreased, and the APT also has normalized. At no point of time there was any indication of, if we ignore this, the SGPTs were always all right. They were not very abnormal. And the albumin, again, hemoconcentration probably, it was around 2.4, 2.5. So we did an ultrasound here and the liver was reported as normal echo texture, liver 7.5 centimeters, spleen of 5.4 centimeter, mild hepatomegaly, nothing specific in the ultrasound. So what is your provisional diagnosis? So Dr. Mrinal and Dr. Arthi. Provisionally, what do you think? So we have the physical examination now, we have some of the investigations now, and you know that there is hypolipidemia, and there is, the amylase is low. You have a stool routine that is showing that there is a lot of fat globules, malabsorption, some blood there, INR which is deranged. So you have liver involved, you probably have amylase lipase low, so pancreas involved, you have the gut involved, there is enterocolitis. So hodgepodge, lot of things happening at the same time. So what will you do at this time? The ultrasound is normal, X-ray is okay.
So provisional diagnosis could secretory diarrhea is present, sir, right now. So
Okay, why do you say just secretory diarrhea or there is something more happening? Because you have all these levels which are funny, the amylase, lipase, and your lipid profile, your INR.
yes, sir.
So can you explain by a single system, is it liver? Is it biliary system? Is it pancreatic? Is it GI? What is wrong with this baby? Okay, we'll ask the experts. Dr. Anil.
So I would say there is definitely a multisystemic involvement. And as you said that the stool frequency was reduced by more than 50% when the child was kept NBM. So this goes more in favor of an osmotic diarrhea. There is definitely liver involvement in terms of coagulopathy. There is malabsorption in terms of hypoalbuminemia. There is a low lipid, definitely a severely low lipid profile which is going on. So that there, then and there, we are thinking of, and plus there is a third degree consanguinity which started as early as maybe 2 or 3 weeks of life. So we
Yeah.
are thinking something as we call as COD or COD, that is congenital diarrhea and enteropathies.
Excellent. Okay, so that is how we summarized. We said chronic diarrhea, failure to thrive, severe dehydration, anemia, coagulopathy, hypolipidemia, low amylase, low lipase. So our DDs were chronic infective diarrhea with malabsorption, some fat malabsorption syndrome, pancreatic exocrine deficiency, cow's milk. There is no history of any cow's milk intake in the baby or the mother. So we did not think of it really. Congenital syndromes. Now that is something that has to be added. What about, sir, congenital chloride diarrhea? How does it present? It's an interesting condition.
So congenital chloride diarrheas or congenital sodium diarrheas, they present as very severe diarrheas. They are essentially secretory diarrhea. So whenever the child is kept nil by mouth, the diarrhea is not going to get better. They are going to keep on pouring loose stools to the tune of 12 to 15 times a day. And importantly, one of the important history which these kids give is, if you ask the antenatal history, the mother will come with history of polyhydramnios. That is one important thing. And they come definitely with some amount of electrolyte imbalance in the terms of sodium and chloride going haywire. So, and these kids, they will come to you with requirement of IV fluids, which is severe. They'll be requiring parental nutrition for support because of the severe amount of diarrhea. The malabsorption is very, very bad.
Excellent. So what we did was we consulted a pediatric gastroenterologist, and he suggested that we add Creon pellets. And the dose was 6 pellets to each feed. He said continue breast milk. There is no need to keep the child NBM now. Stop all milk and milk products to the mother. So this mother was already not taking anything. We gave vitamin A, D, EK supplementation because there's malabsorption. And SOS, we said if the baby doesn't improve, we'll do a scopy, a biopsy, maybe a whole exome. That was the plan at this time. Do you agree with this management? Dr. Anil, would you have started Creon to this baby?
Not so fast. I would have first wanted to do an ultrasound abdomen, comment on the pancreas, and then maybe may or may not have
So
started.
yeah, so the ultrasound abdomen, actually the pancreas were not very well visualized, and we did not actually do a CT abdomen or an MRI to look for the structure of the pancreas. We were not able to do that at that time. But we added, anyways, we took this advice and we added these Creon pellets. So this Creon pellets, they were started. The dose was 3000 lipase units per 120 ml of formula or on the breastfeed. So we started. 1 week later, what happened was interesting, that the consistency of the loose stools improved. The fat globules in the stool decreased. The dyslipidemia got corrected. And it was advised to increase the lipase dose. So if we see here, after 1 week, the cholesterol from 10 became 18, triglycerides increased, LDL increased, VLDL increased. HDL increased from less than 5 to 24. So we are happy that, this child has clinically responded and his hypolipidemia has got corrected to some extent. So that was how it was. Now, one of the questions I had in mind, would you have thought of, cystic fibrosis in this child? Is it possible that this child has cystic fibrosis?
So cystic fibrosis comes with a lot of mutations, as we already know. So there are certain mutations, type 5 and 6. They come with specifically GI involvement and no respiratory involvement whatsoever. Not at the early life, not even at the later stage in life. So it is a possibility clinically, yes, that patients with cystic fibrosis can present only with GI involvement. And as depending on the type of mutation, whether it is a surface mutation or the trans migration mutation, they can definitely come with such a severe symptom. Yes.
Great. So we also did a sweat chloride and it was negative. Now this is a 1.5 month old baby. So we thought that, the sweat chloride, although it can be done after 2 weeks of life, but we thought that in a very young child, we should do a whole exome and rule it out. And we did a whole exome. It was ruled out. It was not cystic fibrosis. So this child was discharged on breastfeeding, crayon pellets, and vitamin ADEK supplements. He was discharged on a weight of 4.1 kilos. So he came with 3.1. He was discharged on 4.1. His loose motion stopped and he was doing fairly well. His growth monitoring was done regularly. And you can see that, on follow-up also his weight it has increased. So this is the follow-up, actually, the lab, and you can see the cholesterol has normalized, the triglycerides have gone up. In fact, it is little on the higher side. LDL is normal, your VLDL, HDL is slightly low, but the amylase from 18 it went to 45 and lipase went from 5 to 13. So all this biochemistry got corrected and the child also got better. The INR also on the follow-up labs, it's normal. The CRP was normal and the rest of the investigations were also okay. So that is how it went. And the hemoglobin on the follow-up was all right. The WBC was okay. So we did not really worry about these parts. And we were mainly concerned about the lipid and the amylase and the lipase. And that seems to have responded to the crayon, which was given. So this is the follow-up stool routine. And although there are still plenty of fat globules, the child's stool consistency, mother says, has improved. There are a few pus cells and there is no RBCs here. Mucus was present, but earlier it was mucus plus plus. So the mucus also has decreased here. So we did send a whole exome in this child and we got this result. So we had 3 problems on this, and one was mitochondrial DNA depletion syndrome. The second was congenital bile acid synthesis defect. And the third was pro-protein convertase deficiency. So we got these 3. And as we can see, it is all uncertain significance. They are all autosomal recessively inherited conditions. And we tried to read a little bit about this. And we found that, if it was a bile acid synthesis, it would come with cholestasis, fat malabsorption, hepatomegaly, growth retardation, and neurological symptoms. So out of this baby did not have cholestasis, which is a very important feature of bile acid synthesis defect. As far as pro-protein convertase goes, severe early onset obesity, which was not there. Endocrine, this child's thyroid and other hormones were always normal. Chronic diarrhea, yes, this baby had. There was no developmental issue in this child. And nothing was fitting in really mitochondrial DNA depletion syndrome. We completely ignored that. What is your, I wanted to know, Dr. Anil, a little bit about bile acid synthesis defects. How do they present and how do we suspect them?
So BASDs, or bile acid synthetic defect as we call them, they come to us as cholestatic jaundice. That is their usual presentation: hepatomegaly, cholestatic jaundice, and growth failure. That is how they usually present to us. And in these kids, if you do the serum bile acid levels, they will be severely low. So usually when there is cholestasis, the liver is, there are a lot of bile acid synthesis going on. So the serum bile acids will be high in these patients. But in this particular patients with bile acid synthetic defect, the bile acid levels will be abnormally low. And that is when you can think of hinging on prodiamine. But yes, hepatomegaly and cholestatic jaundice, these are the 2 important features. Diarrhea, maybe at a certain point, but no, primarily they come with jaundice and hepatomegaly.
Right. So we did not think that, the child fitted in any of these 3 conditions. We consulted a geneticist who advised further testing. He said torch titers and mitochondrial defects and this and that, mitochondrial analysis, etc. The patient was not affording really, and the patient did not fit in anything. So we have not pursued with investigation. So this is the child, you can see that The child's weight gain is excellent. The baby looks quite chubby now. So in fact, what happened was that this baby is now nearly 7 months old. So the last follow-up we had was around 4 months of age, and then the baby went to some private practitioner, some other pediatrician, and they stopped crayon tablets. They stopped crayon completely, and just some supplements were given. And this baby's weight has now come back again to 3.2 kilos from 4.4 what we had. Now the baby is again 3.2 kilos. He was given Neogain powder and some supplements, and Creon was stopped. The loose motions are not as bad as they were before, but this baby is having loose stools, 5 to 10 episodes of loose stools. Unfortunately, the parents have not come for follow-up. But I wanted to ask Dr. Anil, what are your thoughts on this? Stopping Creon and giving some Neogain powder or something like that.
So at this point of time, difficult to give a clear-cut answer, but what I could assess from the situation is that the child had some amount of malabsorption which was going on. Okay, now this Creon has helped with the malabsorption problem, and that helped the child to gain weight, the stool frequency going down. I don't want the idea of labeling everything right now. If the child is improving right now and we are giving a controlled dose of Creon, which we know we are monitoring along with the weight gain and the type of stools, there's no harm in continuing Creon at this point of time. More so now when we know that for whatever reason it had been stopped and that has caused the fall in weight gain and the back and the return of the diarrhea, I would say. Yeah.
Absolutely. So we are calling this patient back. Unfortunately, they are not following up. But initially, this was quite a diagnostic dilemma because the presentation initially was all gut. And then we got the PTINR, it was leading us to a liver. And then we got low amylase, lipase, and lipids, and it was leading us to pancreas. And then we did a genetic test, and it is not fitting either of the problems that the genetic test showed. So finally, we had not have any clear answer as to what. Yeah, so Dr. Vibor.
Yeah, hey, sorry, I was logged out because of network issues and
Right. But you saw the slides, sir?
investigations. I really don't know. So I didn't see the X-ray and other
I'll
things I have
just
not
show you the
seen. Do we
X-ray.
have
I'll
the
just show you.
abdominal X-ray was done?
Yeah, I'll just show you. Yeah, this is the X-ray.
So if you discussion I did here, see, whenever there is there is a pancreatic issue, okay, the X-ray looks okay, so there is a good rectal shadow is there. Okay,
Yes.
so generally the pancreatic insufficiency doesn't present as a dehydration, okay, or fever. So this presentation is not of like a pancreatic insufficiency which is going on. Second thing, amylase, lipase, the maturity to the adult levels, they reach by 2 years. So low
Okay.
amylase, lipase doesn't have much clinical significance at this stage. So on that basis, saying it that it is a pancreatic insufficiency is very unlikely. Again, the pancreatic deficiencies will not give you anemia, will not give hypoalbuminemia so early, because till when the child was in the womb, child has received all other. Okay, so it's very unlikely, and that the 6 weeks child will have hypoalbuminemia because of even there is a severe pancreatic insufficiency. So I think, and whenever there is an increased frequency, you will get a stool fat droplets. So having a stool fat droplet doesn't mean there pancreatic
Malabsorption.
insufficiency also.
Right,
In any
right.
increased intestinal transit time, your fat globals will increase. That's why there is a quantitative analysis where we do a 3-day fat analysis.
Okay.
2 hours fat analysis, which is practically very difficult to do. So,
Yeah.
and so looking at the presentation, my opinion is it is not pancreatic insufficiency. But as Dr. Anil has rightly said, okay, because there might be helping in the digestion, that's why it might have helped. That is one issue. Then congenital diarrhea, about the chloride diarrhea, they do present with the metabolic alkalosis. Your child presented with metabolic acidosis.
Yes.
With normal electrolytes. And so I will not consider here the congenital, the secretory diarrhea. And this child at the 1 year, 4 weeks, he had the sepsis features. Okay, so some immunodeficiencies or the stasis or something, it can be there. So now if we challenge, all the are heterozygous one, which are autosomal recessive, uncertain, significant analysis. So again, it has not helped us. So in probably a cross-sectional imaging pancreas, okay, if there is really insufficiency, the one of the question you have in the clinical management. And in this situation, I will do a very enema and a manometry to see, okay, there was nothing, because if it is a short segment, because see, this child has admitted, you have given antibiotics, you have modulated the flora. So these children do well for 2 months for to reback. Okay, long history for this child. Okay, so I will still, now we have completed every workup in terms of bile acid synthetic disorder. They will have cholestasis and diarrhea also, both. It will first, the affected organ will be cholestasis. There. So these conditions, mitochondria still there, because whole exome sequencing may not be the complete one. We
Yeah.
have not looked at the
Right.
mitochondrial DNA.
Yes, yes, I
But
agree.
in those children, generally they do not gain weight.
Mm.
Child has gained weight. It can be a transient, but they have severe failure. Wasting also. So we have mitochondrial DNA depletion syndrome, which has presented like this. But
Right.
yes, we'll keep that in a possibility. But I will like to go and rule out Hirschsprung disease by doing either a manometry or at least very contrast.
Great. Okay. So we'll try and get a pancreatic imaging, and we'll try and get a barium done if the child comes for follow-up, and we'll definitely keep you posted. But what about the hypolipidemia? Do you think that is just secondary to the malabsorption, or there is more to it?
So this child has a 1 month history, and when the patient present, is kept NPO and other things. So we really don't know. It may or may not be playing a part in the diagnosis. Sometimes it can be a non-specific findings also.
And what about INR? Because INR of 3 is quite deranged. We've seen so many children with chronic diarrhea. I don't remember many of them having INR so deranged.
So see, they do have a bacterial overgrowth if there is an Hirschsprung. So it's a transient, it's a biochemical derangement. It is not the bleeding. It's not the clinical coagulopathy.
Yeah, there was no bleeding. Yes.
And it got corrected. So it's
Yes.
not. Yeah, and if it is getting corrected after vitamin K, it's a deficiency which is because of malabsorption.
Right.
Which is, I don't know what happened, because I missed those slides.
So
So,
the
but if it is
baby's coagulopathy did not respond to vitamin K. So even after 24
Okay.
hours, the INR was still deranged. It was still deranged.
How much deranged it was?
It was 3, and then it repeat was some 2.7. It did not make much difference at all.
Okay, but later on it improved.
Later on, actually, we gave FFP because we thought that it's not improving, and the stool blood was positive. So we
Yeah, so
gave
another
FFP.
Yeah, so another as an hypoalbuminemia. Your first albumin was 4.2. That was very surprising. So that may be because
Yes.
of hemo concentration.
Correct.
But
Correct.
later on, hypoalbuminemia did come. Now
Yeah.
these all the when you have sometimes if it is suppose it is a GI loss of the proteins, then your proportion of this INR is an in vitro test. So it can
Yes.
be deranged because of your imbalance of the proteins. It may not be
Right.
actually the problem.
Right.
So that can explain the deranged INR.
Right. Okay. All right. So the albumin was low. Subsequently, as you said, it was low. But after follow-up, there was the baby was put on creon, it went up to 3.7 again.
Yeah.
So it was also a little, surprising for us.
So generally, the pancreatic insufficiency doesn't give hypoalbuminemia so early in the life. It doesn't
Agreed.
it doesn't give anemia. It doesn't play role in hemoglobin synthesis, iron absorption, and hemoglobin synthesis. So it doesn't give anemia so early.
So there was one more surprise. I kept it for the last. This child, when the child came to us at 4 months of age, initially when we examined this child at 1.5 months, the spleen was just palpable. And later on, it was almost 4.5 centimeter palpable spleen. So the anemia had got better from 6.1, the hemoglobin when the child came for follow-up was some 9, around 9.5. But the spleen side had increased. The liver had not increased at all, but the spleen size has increased. And we were not able to really explain why the spleen has increased. And it was a firm spleen. So we were not really able to explain why this baby should have, splenomegaly.
Yeah, difficult to fit in.
Yeah, so we were in fact considering referral to even a hematologist to see, they could give any inputs, but this child did not come for follow-up, unfortunately. So actually, we presented this child because there were so many systems involved, and we were not very clear on, how to go forward really. And crayons seemed to help transiently. And because if the child comes for follow-up, we'll definitely rule out a Hirschsprung and we'll definitely do a pancreatic imaging, as you suggested. So thank you very much, both the experts, Dr. Vibhu, Dr. Anil, and the PG students from DY Patil. Anybody from DY here? Dr. Sanjay Chavan is traveling. He is not there.
Yeah, I have joined, sir.
Okay, sir. Yes.
Yeah,
So,
yeah.
sir, comments on this case and how you
Yeah,
students.
it was an excellent presentation by Rajesh, sir. You really led the, you took along our postgraduates and analyzed, and the experts gave in a very good opinion, and it was a very good learning experience for our postgraduates as well as us also. So I think it is an excellent initiative by Maha IAP, and Rajesh is leading this, and it was very good of Vibhor and Anil to give their inputs. Thank you.
Yes, and I must say that Dr. Mrinali and Dr. Aarti did really well.
Yeah.
It's more important that you get the basics right rather than a final diagnosis, which you can see we still don't know the final diagnosis here.
Exactly.
But how to analyze the symptoms, the signs, the investigations, how to think rationally and try and come at an agreeable diagnosis. That is what I learned from this case. And
Exactly.
excellent inputs from Dr. Vibhu, Dr. Anil. Both of you really, explained how things work really, and when to suspect a pancreatic, not pancreatic, liver, no liver, and enterocolitis and possibility of Hirschsprungs, which we did not consider at all. So I must say that that was something we did not consider. And definitely, if a child comes like this again, we'll definitely have that in the back of the mind that this could be a Hirschsprung also. So thank you very much, both the experts and the PG participants. I enjoyed presenting the case. Any closing remarks, Dr. Vibhu, Dr. Anil?
So excellent case. I think sorry if I missed some part because of network issues, but I think it really tormented our brain. Yeah, very nice, sir. And very nice, Mrunal and Aarti.
Excellent
Great.
presentation. Thank you, everyone.
Thank you. So with this, I think we will call it a day. And today is Dr. Ram's birthday. So let us wish him a very, very happy birthday. He's working very hard for Maha IAP, and I have never seen Maha IAP so active. So he's done a great job. Today's birthday, along with Dr. Chavan. And thank you very much, everybody, for